Well, it's really great to be the last presenters in a conference because you get to be nervous all day. So thank you for sticking around. My sister, who really is my rock in a lot of ways, told me this morning that it's really good to do the hard things, and this is hard for me. So she says it makes you feel alive. Here's to being alive. Good afternoon. It's a real pleasure for us to be here, albeit being nervous. It's been a tremendous day so far, really eye-opening, really inspiring, fantastic for networking, and really humbling as a nurse to work within a team, a collective of nurses and experts who really have a tremendous amount of knowledge. So we're really grateful for that. Jeff and I we agonized over the title of our presentation and what we were going to talk about. And I promise we're both sort of people who ad lib and sort of go off on tangents. So we promised we were going to stick to the script, and I'm already not following my rule. So I will get back on track. We decided to call this How a Patient Experience Became a Catalyst for Change. We don't have any actual or potential conflicts of interest. We're going to echo the same sentiment as the others, and we really thank Dr. Espahani and the organizing committee for CanTalks this year because we are so pleased that nursing is a part of it. We all know that the patients we provide care for are complex, and let's face it, it takes a village. Oncology nurses make up a huge part of the population of that village, and we do have a place at the table. So who are we, or who am I guess, to start with? I am the assistant head nurse of the ambulatory clinic at St. Mary's Hospital, and I have always worked there for my 26 years as a nurse. As a result, I may have a somewhat different view from some others, what others may have observed by working at tertiary hospital settings. But when I think about how the community hospital has changed over the last decade or so, I think, of course, of the health reform that changed the solo hospital to the now well-established hospital health networks. And while this change has undoubtedly strengthened healthcare in many ways, it has also forced a lot of change and adaptation in the way things were quote unquote done. Impromptu interdisciplinary team meetings, for example, often require a lot more planning and time to achieve as we now operate as a merged program rather than a solo entity where you might have been able to just walk down the corridor and reach another entire department. Now we're talking about going across the island sometimes to be able to achieve the same goal. Why is this relevant? Well, when we are considering how to implement quality improvement measures, we must, at least as part of the process, examine how did things used to be? How are things done now? What worked then? What works now? Did we forget how to talk to each other, to brainstorm, to learn from each other as we're doing today? Are we all just too busy with virtual meetings and solo online learning platforms to even notice? Don't worry, this is not going to be a rant about how the more, I'll call myself experienced nurse doesn't like technology advancements, not at all, but it's simply food for thought as the presentation unfolds. And I just want to underline the concept of getting back to basics and not forgetting to talk to each other. The cancer program at CIUS Ouest de l'Île de Montréal is comprised of the ambulatory clinics of St. Mary's and of the Lakeshore General Hospitals, as well as a 22-bed inpatient unit with a rather unique dual mission of cancer care and palliative care. Our presentation today will focus mainly on the ambulatory clinics. Our centers treat both solid and malignant hematology. We facilitate or perform diagnostic procedures, including those of the rapid access programs. We offer supportive care like transfusions, hydration, management of disease, and treatment-related symptoms by way of our urgent care clinic. We actively participate in clinical research for both solid tumors and for malignant hematology. St. Mary's Cancer Clinic has place for 25 patients at a time and treats on average 35 patients per day, while our partner at the Lakeshore miraculously functions with only 14 places for patients and are able to treat 25 patients on average per day. So why is our talk relevant? Cancer care is not for those who want to work within the status quo of routine, ever evolving, ever challenging, with treatments becoming more and more complex, and with more and more lines of therapy being made available, and patients as a result living much, much longer. The task to upskill our nursing workforce is quickly becoming urgent. In the infancy stages of our huddles and research for our contribution for this event today, we very quickly realized that cancer centers, not only in our city and in our province, but also internationally, have similar preoccupations and challenges. The role of the oncology nurse is immense. It is multifaceted, it is demanding, and it continues to grow. The oncology nurse is in a prime position to help influence positive patient outcomes by way of skillful, focused assessment, by developing and fostering a therapeutic relationship, by patient education, by encouraging the early reporting of side effects and symptoms, and so on. Finding meaning in the work that you do has really never been more important. The perspective we wanted to shed some light on is that of the community hospital center, where we treat a little bit of everything. How that translates is if I'm working in the oncology clinic, for example, today, I may have 6 or 7 patients assigned to me, all with a different diagnosis and all with a different treatment plan. So I need to know at least a little bit about a lot of things. We have heaps of best practice guidelines from the experts at our fingertips. The question is not, is the information out there? Yeah, thank you. It's not, is the information out there? It's, do we know what we're looking for? Oh, I'm sorry, you're right, Jeff. I didn't advance it. See, I can't do 2 things at once. It's very hard. I do apologize. So how okay, so let me just start that over again. We have heaps of best practice guidelines from the experts at our fingertips. The question is not, is the information out there? It's, do we know what we're looking for, and when are we supposed to look? Or how does this mega hospital protocol work in our little community hospital clinic? Quality improvement initiatives, patient satisfaction, and measurable outcomes are all driving forces for all of us, and being successful all while coping with the ever-changing workforce. What are some of the barriers to timely intervention with novel therapies? The nursing literature outlines some of the major obstacles for clinicians to intervene in a timely fashion when a possible complication or toxicity may present itself in relation to novel therapies. Insufficient clinician awareness, and that this includes not only in the oncology setting, but as well as in our emergency rooms, in family practice, and really in any other healthcare setting a patient may report to. Time and resource constraints, there's no explanation required there. We all face very similar obstacles no matter where we work. Missed communication opportunities, again, the habit of talking to each other, sharing findings, brainstorming, the not getting that second opinion from a colleague, for example. And finally, knowledge gaps and non-adherence to guidelines. Teams are required to identify what the gaps are and to explore why the non-adherence to guidelines exists, to demystify reluctance to use high-dose steroids, for example, or perhaps not using doses of steroids that are too high, lack of experience, insidious patient presentation, and so on. Knowledge is key, like a lot of the other presenters have talked about today, and I think we all believe in that. One of the things that nurses have is the nurse feeling, that trust your gut sort of thing. You just know when something is not right. And that is not something that's scientific, but it's just one of those things that I think every nurse has. And it's really important to listen to that and to listen to your patients. So I'm going to just walk you through a little case study here that just helps to sort of illustrate the point. We're going to go back about 3 years now, so bear that in mind when you hear the patient presentation and the way it was addressed. So I'm going to share with you the story of Mr. R. We're going back 3 years, as I said. One of the many great things about working in a community hospital setting is that you really get to know the patients you treat very well, and that's one of the things that I love about it. I remember Mr. R very clearly, and he and his story have stayed with me even to this day. He was a very lovely 85-year-old gentleman who had been diagnosed with a de novo metastatic non-small cell lung cancer. He had great family support. In fact, his daughter was a nurse, and she worked in a palliative care center. He was very happily married. He often talked about his wife. He worked for more than 50 years in the railway industry. He was of sound mind. He had no major comorbid conditions. At the time of his diagnosis, he was mildly short of breath on exertion, and he was found to have a moderate malignant pleural effusion for which he had been tapped twice before initiating his therapy. He was enrolled in a phase 3 clinical trial and was randomized to the monotherapy PD-1 inhibitor arm. As I'm sure you're all familiar, patients, particularly those who are enrolled on a clinical trial, are very well followed and have several professionals who are interacting with them during the whole process. Mr. R was seemingly doing quite well. His first treatment was uneventful. His main complaint was of fatigue, but he would often laugh it off, saying things like, well, I'm 85 years old with lung cancer. What should I expect, right? He came in for his second treatment after having been cleared by his oncologist 2 days prior, and again, feeling reasonably well, didn't report any new symptoms, but again, he said he was feeling tired. His vital signs were within normal limits, and the infusion of his second treatment was again uneventful. 3 days after his second infusion, his daughter called the urgent care clinic line, reporting a 2-day history of her father reporting increasing shortness of breath and orthopnea. She happened to have a pulse oximeter in her possession. As I said earlier, she was a palliative care nurse who occasionally did home visits for her patients. She said his oxygen saturation was 86% on room air. She found him to be extremely fatigued, and she noticed a new droopy eyelid on the right side. She was urged to bring her father to the urgent care clinic for an emergency assessment. The treating oncologist was contacted by phone to report the patient's symptoms. A COVID swab, a chest x-ray, a CBC, a D-dimer, a Chem10 were all prescribed as telephone orders. The patient arrived in clinic by wheelchair, visibly short of breath, hunched over, even had difficulty holding up his head. He had acute weakness, particularly in the upper part of his body, with obvious ptosis on the right side. My heart sank. During previous visits, he would proudly walk in without an aide, no walker, no cane, and looking very strong. And now here he was, hunched over in a wheelchair. He was mildly tachypnic and hypoxic. He was administered oxygen. Blood work and a chest x-ray were performed as ordered, but it was now blatantly obvious that this patient was gravely ill. The patient was seen by the oncologist on call, who immediately ordered a CK, a TROP, and a BNP, and as you can see, the results are staggering. When we got the blood test results and the on-call physician explained to Mr. R that he had been diagnosed with a very serious condition called triple M overlap syndrome, He skillfully explained that the mortality rate associated with this toxicity was very high, but added if he survived it, it was likely that his cancer had responded very well to the treatment. I can remember clear as day the patient saying, "Well, that explains why I've been feeling this way and why I've been so tired." He gratefully thanked the team for our help. Mr. R suffered a long admission and had aggressive treatment, including pulse steroids, a very long ICU admission, cardiology and neurology consults, IVIG infusions, and a JAK inhibitor. He was transferred to a neighboring institution for specialized cardiology care, and he was subsequently transferred back to our institution and eventually died in our hospital on the palliative care ward. So why did this happen to Mr. R? 3 years ago, we as a collective were required to examine our current practices at the time. And in the age of novel checkpoint inhibitor, antibody drug conjugates, or bispecific therapies coming out as often as what seems like every other day, we simply must do better and not simply react when a toxicity appears. We met as a team, nurses, pharmacists, oncologists, and we decided that we should be proactively screening patients in the hopes of detecting problems before starting therapy and as a means of early detection and intervention once therapy had started. And so, with a physician leader, we reviewed the evidence of what tests are to be performed at baseline and why. Things like the severity of the toxicity, when those toxicities would be most likely to occur, and inspiring ourselves from what a neighboring tertiary center had already started doing, we created 3 standard blood profiles for patients receiving a checkpoint inhibitor as their treatment or as part of their treatment. The baseline panel, which you can see here on the right, includes, amongst other things, a TROP, a BNP, a cortisol, and a quantiferon level, along with a baseline ECG. Another set for cycles 2 to 4 of the immunotherapy or the checkpoint inhibitor, which include, among other things, a troponin level for early cardiotoxicity detection and a CK level for early myasthenia gravis detection. And finally, a set for cycles 5 and beyond to help detect other toxicities that are not fully understood. Once we had the approval from our chief of labs and started our peer education for our groups, which included nurses to nurses, oncologists, of course, pharmacists, but also very importantly, our administrative agents who are responsible for booking the blood tests. And of course, we are all human. People forget things, so it's really important. The more people know what drugs are immunotherapies, the more safeguards we have to make sure that those things don't slip through the cracks. Real-time learning opportunities became a priority for us, sharing information, having a lot more huddles, making the time when quality improvement is connected to real patient experiences and improved outcomes, there is simply no better motivation. Mr. R was really the catalyst for our team and essentially helped the shift from reactive care at our center to a much more proactive approach. I'm going to hand it off to Jeff, who will talk a little bit more about some of the proactive things that we have done now as a result of Mr. R's experience.
Thank you, Jennifer, for that wonderful introduction. Bonjour à tous. Hello, good afternoon to everyone. My objective is to discuss how our team met the educational needs of nursing staff, specifically for checkpoint inhibitor therapy and with the introduction of bispecific T-cell engagers. My hope is that this discussion will stimulate some interesting ideas and highlight some of the work that still needs to be done to ensure nurses are well prepared to meet the needs of our patients. While thinking about preparing for my presentation today, I decided I wanted to not only emphasize the role of the nurse to have a positive impact upon the patient experience, but also how I could help implement an educational plan that would support a more proactive approach to the effective recognition and evaluation of the adverse effects associated with immunotherapy. For my first point, I wanted to emphasize, I realized it was a bit redundant. Any search of available nursing literature and research already confirms the positive impact nurses do have for patients, specifically receiving immunotherapy. Therefore, I started to give more consideration and think about how I could help implement an educational program to meet these goals. I concluded there would be two main challenges. Challenge number one, how to address the educational needs of both novice and experienced nurses. Challenge number two, what's the best way to develop and implement an educational program to support the introduction of bispecific therapy? So, in thinking about meeting the learning needs of both novice and experienced nursing staff, I thought that the andragogic principle of tiered or modular design would be helpful for many different reasons. If you're unfamiliar with this design, it emphasizes a flexible approach and the use of short, structured learning modules. The learning topics or materials are based upon your target audience or learner's baseline knowledge, experience, and the specific goals you as the teacher or they as the learner want to achieve. I also looked at a few other different types of adult learning principles and incorporated them into the program that was eventually developed. Some of those principles included using shared experience to act as a resource, presenting information with a focus upon a specific problem rather than just on content, and providing opportunities and tools to support self-motivated learning. When we talk about shared experience, that's just another way of saying having our more experienced nurses kind of share their practical knowledge or wisdom, which we know in our nursing profession is a very valuable asset that we have. For the second principle of focusing upon the problem rather than content, as demonstrated already here today, using case studies or during presentations, asking open-ended questions will help reinforce not only the relevance of the material, but also increase the ability of the nurses to learn. And then finally, how did I look at how to provide opportunities for self-motivated learning? Well, this simply came down to providing the staff with supplemental nursing learning resources that they could review together or independently. Another benefit I found of adopting this tiered or modular design is that it would fit very well with our recently, at the time, established practice of holding nursing grand rounds, where we would meet together and talk about different various topics or subjects. Based upon the experience of the patient that Jennifer presented during her case study, she helped me identify the team's specific learning needs. Based on this input, I developed a program to review checkpoint inhibitor therapy. This program that I developed was presented in two separate modules during our nursing grand round sessions. The first, or foundational model, served as a review of basic immune system concepts. It included things like the mechanism of action of checkpoint inhibitors, the recommended monitoring required, and a description of both common and some of the uncommon adverse effects. Benefits of presenting the information in this way included: one, it allowed for an introduction of basic concepts, to support later learning that served as a kind of foundation for the more complex subject of bispecifics. Two, it reinforced the knowledge base of the experienced nurses. And finally, three, it promoted the importance of continuing education. The second, or more advanced module, I presented a few weeks later, and it allowed me to introduce more advanced concepts related to checkpoint inhibitors. Some of those concepts included differentiating between immune-related adverse events and standard chemotherapy toxicities, the use of the newly created standardized lab screening panel, which Jennifer described, the role of the patient in self-reporting. Sometimes that's something that's a bit overlooked, or we just naturally assume that they know when and how to contact us. I also reviewed the use of the immunotherapy checklist, a tool that we had already established, but maybe especially in the events that Jennifer described, we thought we could take another look at to see if there was a better way we can incorporate this. And then finally, to kind of enclose the whole picture there, a review of telephone triage and the use of the CoSTARS tool for conducting remote assessments. If for some reason you're unfamiliar with the CoSTARS tool, CoSTARS stands for the Canadian Oncology Symptom Triage and Remote Support Tool. I combined my own personal concept of how to use critical thinking in nursing practice and how I interpreted the use of the CoSTARS evaluation tool in an effort to help our nurses kind of consider some more important questions that they could use in conducting their evaluations. The benefits that I'd hoped to realize after presenting this second and final module on checkpoint inhibitors was to support the nurse's use of critical thinking, to improve the competency with assessment and recognition of adverse effects, and to emphasize the role of the patient. Now we can move on to the second challenge that I had: the best way to implement an educational program to support the introduction of BiTE therapy. For this challenge, my intended objective was to ensure nurses would be well prepared to recognize, evaluate, and intervene when the adverse effects associated with this type of therapy occurred. So because we'd already built up some momentum with our project to review checkpoint inhibitor, during that whole process, we also learned some valuable lessons. I incorporated those as well as some other additional learning principles when I was developing my proposed educational program for bispecifics. Some of those things included: make sure to create a safe learning environment, emphasize the autonomy of the learner, provide support for micro-learning, and provide feedback that helps support the idea of self-regulation or self-improvement. Micro-learning is kind of basically what it sounds like. This is the idea that you present information in short, easily digestible segments. These segments focus upon a specific learning need or can apply to a specific nursing task or role. An example of creating a safe learning environment would be kind of when it comes up in the situation, normalizing each individual's place on kind of the learning pathway or trajectory. We all know that we're dealing these days with a different skill mix and different backgrounds of our nursing teams. I also like to refer to something in teaching some of the newer nurses in the clinic, what I call use what you know principle. These are ways that I wanted to first foster an environment that felt safe for people to learn and ask questions and kind of push their own limits. For emphasizing autonomy, I ensured the team knew where to find and how to use available resources. I can't be everywhere at once. For the micro-learning principle supports, I requested and was graciously given dedicated learning time for our staff. And I was able to help arrange and provide opportunities to foster their education in additional ways, either through allowing nurses to join webinars or in most of the incidences, we were able to invite our drug rep partners in to also supplement the education that we were providing. And finally, there was the feedback part. The feedback model that I prefer to use is based upon Pendleton's rules. This method proved particularly useful with novice nurses from the younger generation. I got a lot of positive feedback from them that they really appreciated how I was able to provide feedback. So we talked about using the momentum that you can gain, but also what lessons can we learn to incorporate into our learning program. So what were some of those lessons that we learned? The three main lessons we learned were be proactive, not reactive. Don't reinvent the wheel, and recognize the need that staff needs supplemental resource materials. Some of the ways that we demonstrated to be proactive included receiving vigorous support for dedicated learning time. It included using a team approach. This approach ensured that we would discuss protocols, our approach to the learning program, educational plans, that I could kind of bounce back and forth with colleagues and management in advance. It also included developing a communication plan. So we had a specific plan in place that allowed specific key members to kind of share information and ideas, but also it served as a way to identify challenges and then have a platform where we could discuss those challenges and propose solutions in real time as they occurred, so as not to kind of be always after the fact. Finally, another way we were proactive is we considered the need of our partners. What's going to happen to these patients when they leave our center? They're going to end up in the ER, ICU. So how could I support those teams with this novel type of therapy? When we talk about avoiding reinventing the wheel, that's another way of saying everything I taught the nurses I stole from the MUHC. There are several partners at the MUHC who I'm very grateful for, and I decided not to name them personally because I didn't ask their permission in advance. But I hope that you recognize those people as you are. I was in a lot of contact. They were very gracious, and it really helped our team out a lot. And I think that's another important principle to emphasize. We are, at least our three major hospitals, part of the Rossi Cancer Network. But I was even able to reach out to some of the other professionals outside of that network. We have a working group in oncology called CEPSI, which also was very helpful. And it really illustrates that the time that we were all kind of thinking about the same things and having the same challenges, but it's always a good idea to have different viewpoints in when you're coming up with a solution for a challenge or a problem. And then finally, we talked about the need for resources. It was immediately apparent, particularly because this was a novel therapy, that the staff needed to have readily available and simple resources to refer to. For example, being that we're an ambulatory clinic, we do a lot of follow-up and reach out to our patients once they're at home. So with Jennifer's guidance, I created kind of an aide-memoire for the nurses to perform telephone triage or to do telephone follow-ups, because again, this was a therapy we had never used before, and I couldn't find anything on the internet. So we came up with something ourselves. This was all throughout this process, this also illustrated one of our pitfalls that we encountered. During this time in the past 18 months or so that we were talking and developing and getting ready for this type of therapy, not only did we find different resources out there that we could rely on, but there was also kind of an evolution of practice standards that happened this time after we did our rollout of these drugs. So this underlines another important point, is that sometimes you have to go back and kind of change your focus or revise things. And that's something that I'm happy to say we're continuing to do. The main point here is that we recognize the need to start planning not only for the staff, but the patient's needs in advance. And I think it paid off personally. That's just me, though. So if we could take a look at the program I developed, some of the highlights. Some of the material I specifically decided to focus upon when we talked about bispecific therapy. We started off with a review of Oncolabor. Okay, the Oncolabor prescription form at that time was brand new to us. We had never used it. We were using a combination of various prescription forms, including handwritten doctor forms, but this was something new. Obviously, this is a new therapy. We had to talk about major adverse effects from bites, which even for me at the time was a pretty novel concept. I had not really talked about cytokine release syndrome a lot in the past. It's not something you would encounter frequently. There was also a new patient trajectory algorithm that was created. Our conseiller soins infirmiers Carte d'Avancée, Hayet, developed that for us. She did a great job. And then she said, okay, here, tell people how to use it. We had to talk about support medications. Some of us has heard about tocilizumab during COVID, but again, it wasn't a molecule we were regularly expecting to use. Being a novel therapy, I had to talk about patient education post-treatment, okay? An example was, what's the protocol now for the patient to contact the emergency room? In thinking about the side effects for bispecific therapy, the process and protocol is going to be a bit different from our usual procedure with standard chemotherapy. In addition to this, I reinforced the use of patient alert cards, which for many types of therapy weren't new, but not very much heavily used or practiced. But being a novel therapy, patient alert cards was an important part of our program. Just to illustrate here, this is the tool that Hayet developed, the algorithm on your right that we had. And on the left was a tool that the pharmacist helped me find online, which is very simple. It's very nurse directed. It just kind of tells all the information the nurse needs to know, including how to prepare the medication. Because unfortunately at our center, after I think 10 or 11 o'clock at night, the pharmacist goes home. So if something happens during the night, the nurses would have to be prepared to do that themselves. Some of the other subjects that I included during my educational program are listed here. And I have to say that, to my horror, for some of this information, there was very little or no clinical material, at least that I could find, available for me to consult. The last question for my educational program was timing, okay? Solely based upon my own common sense and what resources I had in front of me, I decided the best way to implement the program to educate the nurses was to start several weeks before our first bispecific therapy patient would start therapy. In addition, I kind of had planned for just in time, sometimes the day of or the day before the therapy, where I would do a very quick, brief review. I made myself as available as much as possible during and after treatment in case staff had questions. And I was also very fortunate in our case, because of the way we rolled out the different molecules, to arrange presentations from our partners, from the drug companies, that could come and give presentations to the nurse very close to or just before a new molecule was introduced. To supplement this, I also created little summary sheets for the nurse, which specifically targeted not all the information about the drug, but just some things specific to nurses. As a bonus for me, a little silver lining, in preparing for my speech today and doing research, I had discovered that nursing education research actually has evidence that this is the best way to do it. So for once, in many years as an adult, my intuition paid off. So what can we conclude? So I'd like to review what we've learned, and I would like to then ask for help. So what have we learned? We learned the importance of considering staff needs when creating educational programs. We learned the importance of listening to our staff when challenges or the unexpected occur and to be able to react appropriately. We learned, obviously, that you need to decide upon formalized guidelines and evaluation tools in advance. We learned that being flexible helps achieve successful outcomes. And I think the whole experience reinforced to all of us that even in the only about 25 years or so I've been practicing as a nurse in oncology, therapies and the patients that are presented to us are much more complex now, and we have to think outside of the box from traditional methods of education. This leads to my last point and what I'm going to ask for. What do we need? What do we need to keep growing and learning? We need dedicated learning time and formalized educational resources. We need to continue to encourage partnerships with our patient. We need to support peer-led education efforts. This includes nursing educators, nursing staff, drug reps, doctors, pharmacists. We need to continue to help nurses develop critical thinking skills, assessment skills and critical thinking skills. Those are our two main things. And finally, our own center in particular needs to look at ways to validate what we've been taught over these past 18 months, how we can validate what we've learned, and how we can maintain competency. I want to thank everyone here for their kind attention at the end of the day. And I hope that you found not only our presentation, but the other presenters here today as useful and helpful as we have. Jennifer and I are here. If you have any questions or comments, we'd be happy to answer them for you. Thank you so much.